All right, we're right at the top of the hour, so we'll go ahead and get started. Good afternoon, everyone, and good morning to our friends on the West Coast. We're thrilled that you could join us for our first conversation series program of 2021. My name is Corey Bryant, and I'm proud to be a member of the Alliance team and helping to facilitate today's conversation. If you haven't already, we really want to hear from you today, so let's make good use of the chat. So pop down to the chat, tell us your name and the program that you're representing, and a little bit about why this topic is of particular interest to you. And later on, if you have some specific questions for our presenter, we'll make use of that Q&A button down at the bottom, but I'll remind you of that as it gets a little bit closer to time. Also, a quick announcement before we get started. Our work group has lined up some incredible conversation series topics for you this year. These are all cost-free, fast-paced programs that take on critical challenges affecting the community of practice. So check out our upcoming programs by going to organdonationalliance.org. And under the Learning Programs and Collaborative Events tab, you'll see the conversation series. So you can see our upcoming lineup there. And this is also where you can go to view on-demand versions of our previous programs, all at no cost to you. So big shout out to my colleague Glenn Matsuki here at the Alliance and our Conversation Series work group for putting this incredible lineup together. We're really excited for what this year has in store for this program. So without further ado, I'd like to introduce the moderator for today's program, Dr. Gwen McNatt. Gwen is the Chief Administrative Officer for the Organ Transplant Center at the University of Iowa Hospitals and Clinics, and she also serves as a member of the Alliance 2021 Conversation Series work group. So Gwen, it's a pleasure to have you with us, and at this point, I'll turn it over to you to kick off our program.
Thank you so much, Corey. And welcome to everybody. I think you're going to find this a very interesting presentation. It's my pleasure to introduce Dr. Adyr Moss. He's an associate professor of surgery and the chair of the Division of Transplant Surgery at the Mayo Clinic, Phoenix. He did his surgical residency at the Cleveland Clinic and his transplant fellowship at the University of Minnesota. He has a very impressive CV with history of presentations on a variety of topics given throughout the world, as well as many peer review journal articles. His clinical interests include both abdominal transplant and hepatobiliary surgery, as well as protogenomics. So without further ado on my part, let me introduce Dr. Moss.
Thank you, Gwen. I'd like to thank the Alliance for the opportunity to share our experience with our strategies to increase organ utilization that we've implemented many years ago at Mayo Clinic Arizona, and show you how these strategies have impacted our program. I think it's important to set the stage for the talk. Is you need to think about how things were like 8 to 10 years ago, so you can understand the rationale for what we did. So if we look at the number of, and I'm going to talk about liver transfers because that's what kind of drove our change in strategy. And along the talk, we're going to talk about the kidney transplant as well. But if we look at the liver transplants in the United States, it's easy to see that up until 2019, there were about 9,000 liver transplants, which was a significant increase in volume compared to the years prior. But if you look at the number of candidates that were listed, at the end of the year, we still had about 12,500 candidates. So although we're doing well in terms of the increase in number of transplants, we're not really making a huge dent in the waiting list. In addition to that, if we look at the waitlist mortality, yes, the waitlist mortality has decreased to about 12% as of 2019. It still is very high, and if you look at the panel on the right side, there's a huge variability in waitlist mortality among different areas of the country. So the problem is still there, although we're making a progress, the problem is still there. This is a snapshot of the OPTN data in terms of volumes for liver transplants. 2019 was a significant year. It was the first time that we, as a community, we did more than 9,000 liver transplants. It was also a time when we did more than 1,000 DCDs and more than 500 living donor liver transplants in this country. If you look really at the data a little more closely, it's fairly easy to understand that starting in 2010, 2012, there was sort of a push or sort of a focus on doing more deceased donor liver transplant. And this is exactly what happened to the across the nation, in spite of the fact that, of course, there was still some strong interest in pursuing patients with living donor liver transplants. That being said, the availability of donors, or the DCD donors in this country is very variable depending on where you live. And to sort of compound the problem, the discard rate for livers from DCDs is still about 4 times the discard rate for bring that donor. So the problem is still there. So with that in mind, this is the way the Mayo Clinic Arizona liver transplant program looked as of 2012. We're sort of a mid-sized program. You can see that the volume for our liver transplants were about 60 to 70 a year. And you can see that we started in 99, we started in 2001. We tried to put some emphasis on living donor liver transplant because at that time, the waitlist mortality was still very high. And we started to dabble on deceased donors, did one in 2009, another one in 2011, 4 in 2012, because we're very, very squeamish in going there. But evidently, our program was in a plateau and our patients were still dying in the waiting list. So the question was, what are we going to do? And after a lot of sort of internal conversations and a lot of introspection of where our program was, we had to make some decisions. And the strategy that we decided to use was sort of multi-pronged. We decided to change the organ acceptance criteria for our entire program, liver, kidney, and pancreas. We, of course, for us to do that, we had to change the local culture and find people within the program that would be able to drive those changes. We, of course, have to design processes to make those changes to be implemented. And of course, work with our OPOs within Arizona and elsewhere, so we could really utilize organs that were out there that were being underutilized. So we really made an effort to get out of the confines of our program and go to the field and make ourselves available to the different OPOs. So when you're looking at our kidney program, we really broadened the acceptance criteria, particularly using kidneys with acute kidney injury, as you can see, donors on renal replacement therapy, high KDPI kidneys, DCDs with AKI, high KDPI kidneys overall, pediatrics on block, long cold ischemia time, and even organs that had questionable biopsies that were done on site. We made an effort to bring these biopsies to our program and have them reviewed by renal pathologists to see if there was any discrepancy, if those kidneys could be further utilized. We don't have a maximum creatinine that was a cutoff. We went really aggressive, even going way beyond the region 5, getting a lot of kidneys from the East Coast as well. Our only exclusion criteria for AKIs was a presence of more than 10% of cortical necrosis and biopsy with more than chronic changes that were read here at Mayo, Arizona. We started using more dual adult kidneys. Of course, that's a sort of a controversial topic, but we have a system where we talk to each other all the time, and we're being very successful utilizing kidneys that were otherwise would be discarded. Pediatric blocks, we made a very strong effort to utilize those. Between 8 kilos and 15 kilo donors, we'd like to use them on block. And when it came to livers, which that sort of kind of drove everything, we started to utilize older donors, donors with elevated liver enzymes, more steatosis, DCDs, which is sort of what we were trying to focus on expanding. Post-cross-temp livers, we had to sort of design a system where we always had the tools in place to use post-cross-temp livers from Arizona or elsewhere. High BMI the donors, and very, very importantly, we had to broaden the capture area for these livers. Remember when I showed you initially, we were just restricted to Arizona once as of 2010, 2012. When we decided to utilize more organs, we had to say, well, how far can we go? And what we decided to do was we went really far. So as of now, and this is sort of was a slow progression, we go as far as Washington State. We have gotten DCDs from Iowa. We've gotten as far as Chicago to get some of the DCDs if they were of good quality. The sort of the rule of thumb is if we have a 3.5 hour flight from the donor hospital to Arizona to Phoenix, we would consider these organs. And how did you make these changes? Well, again, we have to have people within each organ group that was able to push and believe that these changes were necessary, so we could persuade all members of the team to be able to implement them. And again, this is not a surgeon, although it's a surgeon-driven effort, you have to have hepatologists, nephrologists, particularly the referring providers that to understand that we're doing that. These organs, when you even think about liver transplants, there's more blood utilization in the operating room, longer cases. The intensivists are going to start seeing patients that are longer in intensive care unit. They are intubated for a little longer. So utilizing organs that are not ideal has an impact that goes from top to bottom. The OR staff, surgical pathologists, again, we would like to review these biopsies here. So we have a system where we have 24-hour coverage for surgical pathology. Doesn't matter what time of day or night, a surgical pathologist will be available to read biopsies for us. And of course, you have to have your administrators that can help us sort of navigate the intricacies of the hospital as a whole to be able to do that. These changes, of course, need to be monitored. It was, again, in a very stepwise fashion. We have a very strong QAPI program. We do monthly organ offer reviews where we essentially look for every single organ offer that came to us and we turned down and it was accepted elsewhere. We try to look again at the offers with fresh eyes and understand why those organs were not utilized, and if there was a good reason that they were turned down. These are sort of no blame meetings. Sort of there's no judgment. We just need to talk about what happened at that point and why we didn't utilize all organs that came to us. Very importantly, we had to create new relationships with other OPOs that we didn't have a relationship with, and strengthen the relationships with the OPOs that we already had. We made a very strong effort to provide the OPOs with our phone numbers, contact information, be available to everybody at all times if there was a question on some organ offers or some situations that they wanted to see if we were interested in any offers. So we made ourselves 100% available to the OPOs, and actually that has been very successful in our minds. When it came to DCDs, again, let's go back 10 years ago, the surgeons that were here, myself included, we had very little experience with DCD procurements. Our newer partners helped us with learning how to do those procurements. Then we sort of started going just to surgeons, then the surgeon and the fellow, then the fellow and a resident. And now, of course, we have our fellows, and we can go to these procurements with PAs and surgical assistants. So it was a stepwise increase in confidence when we're doing these procurements, which is, of course, very important for the transplant outcomes. For the other procurement surgeons that were not in the Mayo system, there's just a handful of surgeons that we trust that can do DCD procurements for us. And again, the bottom line is we need to speak the same language. If they are on site and say, I don't like this liver, we need to take that to heart and accept their judgment. We came up with this, actually expanded an idea of the Procurement Coordinator. This is slide that tells you about the pre-COVID duties when they were in-house, but they participate essentially in every single a meeting that we have, M&M, selection conference. They know our waiting list pretty well. We built this team over time. In the beginning, our procurement coordinators, they would take regular day call for kidney or pancreas as a clinical coordinator, at night as procurement, having to come to work the next day, which was a burden. And we sort of evolved to have a core group of nurses that they take all our organ calls and help us with essentially all the processes that we need to have in place to be able to do these transplants. And I'm very proud to say that from all these faces that you see in the slide, just 2 of those faces are not with us anymore. And I'm sure they regret not being with us. The process, as you know, is very complicated. It's a very tough job to have, but they have lots of balls in the air, and they essentially do all the logistics. They call us with updates, inform operating room, inform the fellow, inform the transportation, meals for the team, and so forth. So it's without that team, we won't be able to do what we do today. And what happened once we did these things? What happened to our program? This group is very familiar with the SRTR data. This is the sort of transplant behavior for the liver program. The bell curve shows what AZMC, which is the code for Mayo Clinic Arizona, is. We're sort of on the right side of the aggressive side of the bell curve. We accept a lot of the DCD donors who go farther, and our acceptance rate is higher than the national average. In spite of that, we still have been able to keep the medium time to transplant above to the hospital stay to 5.5 days, which is half of the national average. And most of our liver transplants are from away from Arizona, which is the opposite, as you can see, from the United States. Our graft survival is excellent, as you can see, for 1 year in 3 years. And our patient survival is excellent as well. You can see how we stack up with all the liver transplant programs in the country. Very importantly, our waitlist mortality has decreased. It's a fraction of what would have been if we were not doing what we're doing now. And I'm very happy to say that you can see that the waitlist mortality is half of what we expect it to be, where it is based on our patients' population. Going back to that chart that I showed you before, starting in 2012, we started doing more DCDs, and our liver volume actually has has grown quite a bit. We did 182 livers last year. The price to that, of course, is there's just no need to do living donor transplants anymore. So we're just, although we still have an active program, the need to go that route has not been justified at the present time. When you look at our kidney program, it's our transplant rates, and again, we all familiar with these SRTR charts. Our transplant rate is almost 3 times what is expected from us, and it's at least twice the national average for kidney transplants. Our median waiting time for kidney transplant in the United States is 42 months. For us, it's 15 months, which is very, very good. We get patients from California all the time nowadays that they come quoting that they've been told that they need to wait for 8 to 10 years for a kidney transplant. So it's the crisis is there. We just need to be more aggressive to help these patients. Looking at the same bell curve that we saw for the liver, you can see on kidney, I think there's a lot of room for improvement here. I think we can be even more aggressive. We haven't reached our potential when it comes to kidney transplantation by a very, very wide margin. And you can see here that in spite of the fact that you use marginal organs, our median hospital stay is still 2.5 days, which is half of the 5 days that is in the United States. And the price to pay for that is that half of our patients are discharged still on dialysis. So the idea of having a system that allows patients to be discharged to a local dialysis unit to do the remainder of the postoperative care as an outpatient, with the referring providers accepting and understanding that, has been key for the success of our program. Patient graft survival, again, at 1 to 3 years for our program has been also excellent. This is what happened to our kidney program. We started doing more and more extended criteria donors. The volumes, of course, went way up. We did something like almost 440 kidneys last year. The price I had to pay for that is, you can see what happened to our living donor program, and actually there was a dip. So there's a very, very strong interest and a concerted effort now for us to put more emphasis on our living donor program, which again, we haven't even reached the full potential that we have. And overall, what happened to our program is this. This is sort of my last slide. We did in excess of 704 transplants last year, counting 47 hearts. And it's fair to say, and that in the message that I wanted to give is, if this is done right and in a very controlled fashion, I think we can use organs that are out there, they're still on the table with excellent outcomes without really creating a negative impact on our patients. And the benefit of that trickles down to the entire institution is that you bring more patients, there's more revenue, so everybody wins. So I'll stop here, and I'll be ready to answer any questions that you guys might have. And I appreciate the opportunity to share this with you guys. Thank you.
Excellent. Thank you so much, Dr. Moss, for an incredible presentation. A lot of information very fast there. I'm sure we have a lot of attendees who have a lot of questions. So if you wouldn't mind, as we pivot towards the Q&A section here, if you will move over to that Q&A button in your Zoom platform, that's actually how we're going to do the Q&A portion of today's session. If you will enter your questions in the Q&A button, not in the chat, actually in the Q&A section, and any that get entered into the chat, we'll make sure get moved over into the Q&A for you. But I'll turn it over to Gwen to moderate the Q&A portion.
Okay, thanks again. And what a great talk. This is the second time I've heard it, and it's just really just terrific. I think what is really impressive is that you did this, you know, what I would call the right way, in that you got your culture built first, you got your champions, and then you used the quality process all along to make sure you were doing the right thing for your patients. I think that's just a role model for all of us. One question that I had, and a couple people have asked this, you grew really quickly. How did you keep up with staffing?
Well, poorly. So I think I think the way we see it is, and I think I have to say this in public. I think the institution has been very loyal to our group, and I think every time we asked for more resources, of course we had to deliver. So we never went and asked for, let's go shopping and ask for 10 coordinators and more this and more of that. We never did that. So we pushed the envelope in terms of staffing, again in a very stepwise fashion. We increase sort of the big bottleneck has always been the hospital. Our hospital is actually very small. We're in a 300 bed hospital. We're not in a huge 1,000 bed mega hospital. So we had to be efficient. So our system has always been very, very lean from the beginning. So that's why we've been able to work with, I won't say less people, but people had to multitask a lot of times. And that's why we had to have efficient discharge systems, because patients cannot linger in a hospital forever because they just not enough beds.
Yeah.
Same thing for the ICU and so forth. So currently now, I think we have a good number of staff. The surgeons now are sort of, we kind of almost maxed out where we are, but we're hiring more surgeons. So again, if you ask me, can we use more people? Sure, we can. Are we going to get it? Not now. We need to get to the top, get to the sort of when we're the rubber band is ready to snap, and then we ask for more, and they've been very loyal to us.
Good. This next question is from Richard Petrowski, if I'm pronouncing your name right. A very practical question, but one that I'm kind of having a problem with this in Iowa also. About doing biopsies on kidneys. The first one is, would you recommend wedge versus needle? But I think the more important is the impact of using a local donor pathologist versus the transplant center or some other centralized histology. So
in our practice in Arizona, we always do, at least for the kidneys that we do in our OPO, we usually do wedge biopsies. Of course, they have to be deep enough to get enough tissue. We have used quite a bit of kidneys that the biopsy was read elsewhere that they were said that there was too many chronic changes. We have a lot of publications from that standpoint in using AKIs in our program, but vascular disease and so forth. That when you have a nepropathologist that understands some of these changes, how are they going to impact sort of the clinical outcome? We've used a lot of kidneys that came to us from various places that were said that this is an unusable kidney. On the other hand, we had situations where we with biopsies right in our place that we turned down our kidneys, and they were used elsewhere as well. So I think we just have to stick to who's been working with us. If we have a couple of renal pathologists that are available at all times, and once we have our pathology conference and we review this biopsy, they say this is not an usable kidney, we just don't do it. That doesn't mean that other people cannot that will agree with that, and that's why we have these organ offer reviews that we learn what happened to these organs. And a lot of times we go and find out what was the outcome. And if we're wrong, we go back to the pathologist and say, hey, we need to review what we decided 2 months ago with that kidney. So we have to keep looking at the data over and over again to make sure that we're doing the right thing.
And what are there particular tools that you think are best to use to review the data? Like, are you using the UNOS Care tool?
I mean, we have our QAPI program is very robust. We as a Mayo the enterprise, we have a quality program that encompasses all three sites. So we have our quality meetings that we look at our data real time. So as we have accused some data that it tells how things are going to look 2 months from now. So this is the way we should be doing it. We need to be aware how things are today and how they're going to look at the next SRTR report. So that's the way we usually do it.
Okay. Andrea Vandermellen asks, can you talk about your center's stance on the pre-OR aggressive offers and the new UNOS expedited plan for livers?
So I'm not sure what you do by pre-OR. So we have quite a bit of OPOs that they call us for sort of aggressive backup offers. And those are the ones that that's probably what you're talking about. When they think that the local or the center that has accepted that the liver, they're going to turn it down in the OR. And you guys know, everybody, that they are the usual suspects, the programs that are notorious for doing that. I mean, we all know that. So when that happens, they call us and say, hey, we have a donor and we need a strong backup. When that happens, we identify a recipient. Quite often, depending on where this donor is, we keep the patients at home and PO, and we have the OR kind of, I won't say ready to go, because we don't have as many ORs to sort of dedicated for transplant 24/7, but we have the system ready to go. So if the liver is turned down in the OR, and of course we'll look at flights. So what was the door-to-door time? Make sure that there's the surgeon and the team is ready to go. If they turn it down in the OR, all the coordinator needs to do is say, hey, the liver is yours. We don't have to identify a patient. We're ready. The coordinator already talked to us. We already made a decision to use it. So it takes literally 10 minutes for us to say, yeah, send it delivered to us. Quite often we have a plane available, ready to go in place. And then if we do that, then what happens is we can use the liver with a very short cold ischemia time. Half of our livers from that are shared still have a cold ischemia time of less than 5 hours, which is pretty good.
Yeah. Felicia Wells Williams asks, can you repeat the information about the use of unblocked kidneys and the weights you consider?
So the unblocked kidneys, it's a moving target, and still now, and again, we're 7 surgeons now. Every time we have a situation where we have either older donors or biopsies that show cortical glomerulosclerosis, that the kidneys are going to be discarded, but they can give us sort of a dual unblock. We try to identify a local recipient, because a lot of times these kidneys come from elsewhere. A local recipient with a low BMI, without vascular disease, that we can put these kidneys in. And almost in the totality of cases that we do, we always call a friend. So if I'm the surgeon deciding on that, I usually call a surgical friend to say, hey, what do you think? Can we use this? And of course, always get involved one of the nephrologists. I mentioned the Ramuzi score in that slide, and I'll be happy to. This was a paper published in the Journal of American Society of Nephrology in 1999, and there's sort of a table and a score that they sort of decided which kidneys have an adequate outcome to inadequate outcome. I'll be happy to share the paper with the group if you guys want. I have a copy on my computer.
That would be great. And I just mentioned that a PDF of these slides will be available after the webinar.
What I can do, I can probably add a PDF of that paper and send to everybody if you guys want.
Paul Lang wants to know, what are your criteria for pre-liver recovery biopsies?
I'm not sure exactly what that means. So which patients require biopsy? So all patients that are hepatitis C positive require biopsies.
I'm guessing this means before that they're talking about during the recovery you get a biopsy. I guess this is like biopsying the donor before you go for the recovery.
Right. So if it's pre-recovery, if we can get the biopsy available, we do for all patients that have hepatitis C. So we don't have to fly to God knows where with the patient have too much fibrosis because of hepatitis C. All the other ones we don't require biopsy. So we have if I think in reality, in our opinion, a lot of times biopsy can be misleading because it depends a lot on the reading of the local pathologist. So I think an experienced surgeon that can assess steatosis and how the liver feels, it's the most important thing to us. I have to say that our biopsy utilization for liver is actually fairly small. We don't require. As a matter of fact, some of our surgeons don't use biopsies at all. So we don't have sort of a cutoff criteria, except for Hep C positive donors.
Interesting. Belinda Jones asked about your patients that are discharged on dialysis. I'm assuming that these are DGF patients, right? And how long do they remain on dialysis?
It varies. I mean, you can have a 18-year-old with AKI, that was on CRT, and those patients usually, I mean, they can be on dialysis for a couple of runs. They can be on dialysis for a week or two. We had patients that are on dialysis for a month, and those are pretty much the patients that had their older donors, or they had some degree of chronic diseases. But biopsy there was no acute changes, and they usually recover. And the graft survival is actually very, very good. Of course, we're not going to put those kidneys in very young recipients, right? So high KDPI or AKI kidneys, we're going to tailor those organs to recipients they'll benefit from it. So I think that's where if there's an art, I think that's where the art is.
Absolutely. Paul Lang wants to know, for DCD donors, how long will you wait for circulatory time of death?
So we like to do 30 minutes. So from extubation to flush. And we like to do from arrest to cross clamp with less than 10. So, and this is again, it comes from some data from Mayo Clinic in Florida. They published their experience with DCDs, and that's sort of the magic number that we have. So we've had some patients that in some programs go to 35 minutes and 40 minutes. In the beginning, we kind of wanted to push to 35 minutes. Then a couple of those patients had biliary problems, so we kind of went back to 30 and get more numbers. And then we're going to look at our data again and see if we can go to 35. So that's what we've been doing all along with all extended criteria donors in our program.
What do you think about ex vivo liver perfusion?
Well, we're part of the national trial. We use the OrganOx machine. So our experience was very limited because of there were some issues when we were part of the trial, that the machine was not allowed to be flown anywhere. So because of where we are in Arizona, the distances are so high and a lot of our donors are elsewhere, we couldn't really fly with the machine to bring the machine to the donor, to put the liver on the machine and bring it back. So our experience was very, very, very limited. We had the machine here. Again, it's been sitting in the basement and we haven't used it. But I think that as soon as this becomes more routine and we can use the OrganOx particularly in a sort of more clinic-oriented fashion, I think that's going to change the entire landscape of liver transplants. I think we're very excited to be able to use that. I think we're going to start using livers that we don't use now. I think we'll be able to put them in the perfusion machine and see how they do, and utilize more organs like they do with lung. So I think it's around the corner. I mean, this is already being done in Europe a lot. So I think we're far behind our colleagues from Europe in using these methods. But again, the FDA has been very sort of has been sort of a roadblock to get this implemented in the United States.
Well, I think, yes, I think that and the cost of the disposable items associated with
Right. But again, what's more costly, right, is a patient, is that those disposable items, or is death on the waiting list, right? Or patients that are, they are lingering for years and years. They can't work. They can. So that's it depends how to look at it. Yes, yeah, it's more expensive, and these patients are going to have more ICU stay and so forth. But our goal is to decrease the mortality and waiting list, and I think they'll be worth it.
Absolutely. Just, we don't have any more questions in the Q&A, but I had a question about your biliary complications with the DCDs. Just, is that a big problem?
So,
I've had both experiences. I'm at my old institution. We seem to have, for a while, lots of them. And we use lots of DCDs here at Iowa, and we have very little biliary complications.
Right. So our biliary, sort of the non-anastomotic biliary strictures that we call. So in our initial 40 transplants that we did, 40 DCDs, our ischemic angiopathy rate was 25%, which is, of course, very high. Then we sort of, but again, we're learning how to do the donor, as I explained. That was sort of a honeymoon. We're trying to find out how can we be better at this. The latest iteration that from our data, and I think it was after 200 and I want to say 240 DCDs, we've done over 300 now. Our ischemic angiopathy rate is about 10%, which is very reasonable. Can it be better? Yes, I think it can. But I think 10% allows us to keep doing what we're doing. I think it's important to have very aggressive, of course, endoscopists. From those patients, half of those patients, actually a quarter of those patients will require retransplants, which is, again, very good. And a lot of them require endoscopies and stents and so forth, but most of them do actually very well.
Good. That sounds great. So I think we're about time to wrap it up here. I really appreciate your talk, Dr. Moss, and appreciate the Alliance for having this conversation series.
Yes, absolutely.
I appreciate everybody and everybody coming here today for this. And if there are any additional questions or anything I can do, we can I can provide my email. You can feel free to reach out, and I'll be happy to give any information you guys might want. Appreciate it.
That sounds excellent. Thank you so much, Dr. Moss. And on behalf of the Alliance, our sincere thanks to Gwen McNatt and to Dr. Adyr Moss for an incredible conversation series discussion today. And to all of our attendees, we want to thank you for joining us, and we look forward to seeing you again next time. And until next time, please stay safe and healthy and well, and take care.
Thank you.